So now I'd like to share a brief overview of the cancer support community. The cancer support community was founded as the wellness community in 1982 by Dr. Harold Benjamin in Santa Monica, California. Gilda Radner joined the wellness community during her journey with ovarian cancer. After her death, Gilda's friends and her family started Gilda's Club in New York City in 1995. The wellness community and Gilda's Club joined forces in 2009 to become the Cancer Support Community and create a footprint of over 150 affiliate and satellite locations across the country, as well as a few international locations as well. Everything is free of charge with this mission in mind, to ensure that all people impacted by cancer are empowered by knowledge, sustained by action, strengthened by action, and sustained by community. These are some of the programs that CSC offers at a national level. Social distancing may add to feelings of isolation for cancer patients. My Lifeline allows you to create a private site to keep your community involved in your cancer journey, or join more than 2,000 online discussion board members, supporting each other with information, opinions, stories, and inspiration. An integrated cancer distress screening tool like Cancer Support Source can help identify concerns that need to be addressed early on in diagnosis before they become a barrier to care. The Cancer Experience Registry is a compilation of the experiences and issues that impact the lives of people living with cancer and their loved ones. Frankly Speaking is a cancer education series that provides trusted information on a variety of topics important to people affected by cancer. You should have received those materials in your toolkit, and they can also be downloaded for free from CSC's website. The helpline provides guidance, resources, and support to cancer patients and their loved ones with a variety of needs, from getting information about cancer, identifying a local support group, or just finding someone who's willing to listen. And then lastly, Open to Options is a decision support counseling program that can help you prepare for an appointment in which you'll be making a treatment decision. On a local level, CSC affiliates, including ours, the Greater Cincinnati, Northern Kentucky location, offers programs that fit within this program model. This includes support and networking groups, healthy lifestyle activities, educational opportunities such as this one, social opportunities, as well as resources and referrals. While we have a wonderful building located in Blue Ash, all of our programs right now are offered virtually over Zoom until it is safe to return together in person. You can find them listed with information on how to register on our website, which is listed at the top, mycancersupportcommunity.org. Now I'd like to introduce Kristen Parker. She is the Manager of Patient and Community Outreach for the Ohio River Valley region of the Leukemia and Lymphoma Society. Let's see.
Thank you, Jamie.
Yeah.
Hello, everyone, and thanks for joining this evening. As Jamie mentioned, my name's Kristen Parker, and I'm the Patient and Community Outreach Manager for the Leukemia and Lymphoma Society for the Ohio River Valley region, which consists of Kentucky, the tri-state area, as well as Columbus. Our main office is also located in Blue Ash. The Leukemia and Lymphoma Society, our mission is to cure leukemia, lymphoma, Hodgkin's disease, and myeloma, and to improve the quality of life of patients and their families. We fund research to help advance life-saving treatments. We drive advocacy for policies to protect patients to access life-saving treatments, as well as providing support to patients and their families, with hope that guidance and education and support will help them lead them through their cancer journey. So at LLS, a couple different resources I wanted to point out to you all this evening. We do have our Information Resource Center. So our Information Resource Center, also known as our IRC, can help you deal with any challenges from your diagnosis, while providing information about your treatment options, additional resources that you may be needing, They also do conduct individual clinical trial searches for you to help develop a list of questions to ask your doctor about participating in a clinical trial, as well as being able to help you not only to identify that clinical trial, but to navigate your way through the clinical trial process. In addition to our Information Resource Center, we do provide various other support and resources. So Jamie, if you don't mind just switching to the next slide. So the first resource that I wanted to share with you all tonight is our support options. So one of my personal favorite support programs is our First Connection program. This is a peer-to-peer mentor program that would actually match you with someone of the same diagnosis and similar cancer journey. So whether you're looking to speak with someone about survivorship tips and tricks and something that they've already been through and share your cancer story with them as well, this is a great option. All of our volunteers are fully trained, and it's a great way to not only connect with someone else, especially given the virtual world. Our First Connection program has made a lot of lifetime friends through it as well, with making these connections with someone else who shares the same similar journey and same experience that you have. Another option that we do have available are our online chats. If you do go to our website, lls.org/chat, you'll see a variety of different chat options available, from disease-specific chats to cancer, going through cancer during the pandemic and COVID-19, as well as chats for caregivers and various other options. We do have our LLS community, which I like to call our Facebook of LLS. It is fully staff-driven as far as making sure appropriate content is placed on there and whatnot, but it's your chance to connect with other survivors and patients. There's various different groups based on disease type or something specific that you're looking for, as well as daily questions asked and posted daily. We also do have support groups both through our online chats as well as locally. And currently we are also in the virtual world as well. So all of our support groups as well as our programs will be held virtually. We do have a nutritionist that is an LLS staff member that holds consultations. Currently, she's booked a couple weeks out, but going to this website, lls.org/nutrition, you can set up a 30-minute consultation call with her to help go through all of the nutrition needs that you need going through your cancer treatment or post-cancer journey. And then lastly is our Health Manager app, which is a newer app for us, which is really exciting. It's a great way to not only log your food and your activity, but also help set reminders for appointments and different medication and things like that as well. So on to our education, we do provide various education programs both nationally as well as locally. We do host nationally various different webinars and webcasts based on different types of disease specific, depending on your cancer type, whether it's MPN or looking for survivorship skills, things along those lines are what our webcasts typically entail. We also do have free education materials such as booklets, fact sheets that can be ordered online or downloaded online for free. Also, by calling our Information Resource Center, they are able to ship those materials to you as well. And lastly, we do have our podcast. So our Bloodlines with LLS, it's a podcast similar to our webcasts that have various different topics on a monthly basis that are also posted on our website. If you have any additional questions regarding any of these programs, resources, or support opportunities, please feel free to contact me. I'm happy to either enter in my information on the chat, or Jamie, feel free to share it post-program, but feel free to contact me at any time and I'd be more than happy to help.
Thank you. So now I'd like to introduce our keynote speaker for this evening. Dr. Edward Faber is a medical oncologist, hematologist, blood and marrow transplant specialist at OHC. He has a special interest in malignant hematology, benign hematology, and autologous and allogeneic bone marrow transplantation. Dr. Faber is a principal investigator for multiple myeloma clinical trials at OHC and a member of OHC's CAR T cell therapy team, the only cancer experts in the region certified to offer this revolutionary treatment to adults with blood cancers. After completing his undergraduate degree, Dr. Faber received a Master of Science in Genetics and Molecular Biology from Duquesne University while supervising the Molecular Diagnostics Lab at the Western Pennsylvania Cancer Institute. He received his medical degree from Lake Erie College of Osteopathic Medicine and completed a dual residency in osteopathic and allopathic medicine at the University of Pittsburgh Medical Center, Mercy Hospital. He completed his residency in internal medicine at UPMC and a fellowship in hematology and oncology at Michigan State University. Dr. Faber is board certified in internal medicine, medical oncology, and hematology by the American Board of Internal Medicine. Dr. Faber served as an assistant professor of medicine at the University of Nebraska Medical Center and served as a multiple myeloma and Waldenstrom's, I'm going to mess this up, macroglobulinemia panel member for the National Comprehensive Cancer Network. Dr. Faber is a National Physician Advisor for the Education Project of the Association of Community Cancer Centers, improving quality care for multiple myeloma, and has been appointed as an advisory panelist for amyloidosis for the American Society for Clinical Oncology's Cancer.net editorial board. Among his many awards, he was nominated as Man of the Year by the Leukemia and Lymphoma Society in 2013. While I pull up his slides, please help me in welcoming Dr. Faber. Okay, Dr. Faber, can you click unmute, please? There you go.
All right. Thank you, Jamie. That was very kind of you, and it's a pleasure to be here this evening. And I would like to thank those of you at Cancer Support Community, as well as the Leukemia Lymphoma Society, to spend an evening together. It's been a little rainy, and it's a very nice evening, so hopefully we'll make it enjoyable. And although it'll probably be dark when we're done, which I'm getting used to, leaving in the morning dark and going home in the dark. So, I think there's a lot of renewed hope for our patients with myeloproliferative neoplasms. It's a very busy field and a very busy landscape. And I'm excited to be able to talk a little bit about what I know at least, and then be able to answer questions, because for all of you on the call tonight, those of us that provide care, sometimes we learn just as much, if not more, from you as you may learn from us. So next slide, please. And yep, so for here, this talk is centered towards patient level information, and as information is getting more involved, it has to be involved. I believe that in treating our patients with myeloproliferative neoplasms, managing symptoms is paramount. And so I built into the presentation a review of some of the science, because it's important to understand the treatments and the new treatments that are coming down the pipeline, and then as well as managing symptoms, because they go hand in hand, I think more so than some of our other blood disorders that we treat. Next slide. So hopefully we only have about 45 minutes, so we'll not be able to provide a comprehensive overview, but that's what the question and answer session is for. And as always, this is meant to be very informative and interactive, and certainly suggest that taking information back to the providers and those of your healthcare team. Next slide. So part of my history, I spent some time at the NIH, and when you're by yourself, Baltimore and DC is a pretty big place. And so there were times on the weekends when I was by myself that I would find myself in the National Library of Medicine. And so the history of medicine is very interesting to me. And so Dr. Damashek, back in 1951, first started to recognize these disorders. And I offer this slide because you see the diagnoses, ET and PV and myelofibrosis, and the possibility of bleeding disorders and clotting disorders and progression to leukemia. And that's been 70 or so years. And really until recently, we haven't had much advances. And so it's important to remember history here and how long it has taken for us to get to where we're at. Next slide. And so the World Health Organization helps us try to understand the different blood disorders and blood cancers. And as information becomes available, certain diagnoses remain the same and others are able to be understood better. And so the classification was updated about 4 years ago. And some of the bigger changes is primary myelofibrosis now has a few different versions to correspond with its clinical course. For here, there are leukemias like CMML and CML and MDS, which we will avoid in today's talk to keep the scope focused just to ET, PVERA, and myelofibrosis. Next slide. And for those of us that like a more simpler version, this is something that is an older slide that I've had for many years that a very good pathologist gave me. And the challenge for the myeloproliferative disorders or neoplasms are that they can overlap and they can share characteristics with each other. And I've always liked this slide because it's very simple, and the way that the circles cross over reminds me of those features that share, and sometimes the variability in outcomes that we have to the same treatments, as well as the variability in symptoms from patients to patients. Next slide. So this is just a nice review of the three largest MPNs, polycythemia vera, essential thrombocythemia, and then myelofibrosis. And off to the left of the slide, you'll see the Philadelphia chromosome positive and CML, which, as I mentioned earlier, is related in this family, but we will exclude. The possibility of PVERA as well as ET changing to myelofibrosis is always the concern, especially as time goes on. And our younger patients, maybe their third or fourth decade of life, and then eventually the risk of moving forward to AML. Next slide. And for here, I like this slide because if you remember 2 slides ago, it was an older slide and it said myeloproliferative disorder, and it's been renamed for myeloproliferative neoplasm. And neoplasm can carry a very scary connotation to it because many times we look at neoplasm as a cancer. And I struggled with that reclassification name myself. And so for here, it definitely has a different meaning and a different meaning than cancer itself. And although they both can share that same designation, you know, neoplasm doesn't always necessarily carry the connotation of a cancer like an acute leukemia or multiple myeloma or lymphoma. Next slide. The MPNs are liquid tumors because they start in the bone marrow and they can involve the peripheral blood. And unlike our solid tumors or our solid cancer tumors, they begin in solid organs like the lungs, colon, prostate, and so forth. When we talk about staging, sometimes certain staging systems that we're aware of from the more common cancers are not as applicable and translate to our MPNs. And so we have scoring systems as far as the burden of what the MPN is causing on that particular individual patient that we're caring for. And it's just a little bit of a different concept. Next slide. P-Vera affects about 100,000 people in the US. And I think that there are some individuals that probably go undiagnosed, depending on how often they seek medical care and where the normal range is as far as the hemoglobin and the hematocrit levels. Essential thrombocythemia is a little bit less common, about 71,000 individuals. And myelofibrosis is the least common, and you see there between 16,000 and 18,500 people. That does not include the secondary myelofibrosis that can develop from P-Vera or ET. Next slide. So many times when we talk about our blood disorders and our blood cancers, bone cancer is included, sometimes correctly and many times erroneously. And so what we see in the peripheral blood always begins in the marrow, and this slide is meant to remind me of that. The marrow functions to make red blood cells and white blood cells and platelets as the body uses them and turns them over. And so the MPNs are a bone marrow disorder, even though we call them, blood neoplasias or blood disorders. And these changes in the blood stem cells, which lead to the creation of red cells and white cells and platelets, can lead to the overproduction of one or more of the different blood types. And so we think of P-Vera as having too many red cells and ET as too many platelets and maybe myelofibrosis too many white cells. But if you remember my slide that I offered the circles and the overlap, eventually with many of these disorders, you can have a variety of blood counts that are too high and too low. Next slide. Some of the characteristics that are common for the different MPNs, of course, the abnormal blood cell production and counts. The spleen can become enlarged, and that's usually associated when the bone marrow is overproducing these extra products of the stem cells. And when the marrow doesn't function as well, the body tries to revert to embryological mechanisms of making mature normal blood cells. And so for all of us at one time, that included the liver and the spleen. We see that in our newborn children. The liver and spleen is big, and then by 8 or 9 months, usually the spleen and the liver return to a normal size. The one thing about the MPNs, we can think of infections and other issues related to leukemia, but folks can acquire both bleeding and clotting disorders, which have lead to a variety of potential complications based on the individual health issues of any given patient. And the symptoms here, this is just a very quick review, and I have more slides later on specifically for each disorder. But the fatigue and the night sweats and the itching seem to dominate many of the presentations. Next slide, please. The enlarged spleen, this is again to review, as it overworks. It can take up more room in the abdomen. It moves the stomach out of the way, so to speak, in the abdomen. If it is enlarging quickly, you can have pain or discomfort. Appetite can be decreased, and feeling full very quickly, or what we call early satiety, can also follow. There's also pressure that can be on the kidney, and as well as the large and the small bowel. Next slide, please. Clotting can also be a very serious issue, and especially when you're bleeding and clotting at the same time. And that is a very challenging clinical scenario, because the treatment for one fuels the opposite of action that is happening. And so we can see this in veins that return blood to our heart. We can have deep venous thrombosis in the legs or the arms, clots in the lungs, and sometimes we can see clots in the portal vein, which is the vein that returns all the blood supply from the stomach to the liver first. As we absorb things from our stomach, it passes the liver to be detoxified and purified, and that comes through the portal vein. On the artery side, which we know that carries blood from the heart that's oxygenated to the rest of the body, we can have clots or thrombosis, and that can lead to strokes, heart attacks, and other versions of peripheral vascular disease. In later stages of MPNs, you can have microvascular clots. So these are clots in the tiniest of blood vessels, and those can start causing problems with blood supply to the small intestine, the kidneys, and other parts of the extremities. Next slide, please. So since 1951, when these disorders were first described, we have had understanding of these particular disorders over the last, say, decade. And our understanding of genetics and mutations has fueled that advancement. And so we can inherit mutations from our parents. Many of them remain silent and do not cause many problems. We also can acquire mutations due to toxins, other substances, or just by happen chance as we get older. And you can see here the graph, with each decade of life, those mutations get higher and higher. So it's a double-edged sword for our blood disorder and blood cancer patients. Our immune system sometimes fails to recognize cancer cells or precancer cells. Plus, we have a predilection for forming them a little bit more often than we did when we were younger. So as we get older, these events can lead to these disorders, and that's exactly what we see with the MPNs. Next slide. So the mutations that are associated affect the way cells communicate and as well as how they grow. And the pathognomonic, the paramount mutation was this thing called JAK2 mutation. And it stands for just another kinase, or some will see as Janus, because Janus is the Greek god that had a double head and can be two-faced at times. And so we've learned that the JAK protein is very important in the production of blood cells, and when it's mutated, it can lead to overproduction. The interesting thing about this is that the same mutation can cause different blood disorders. And for CML, or chronic myelogenous leukemia, which I've omitted here, it was truly the first blood cancer in 1960 to be associated with a genetic mutation, and that is what we know as the Philadelphia chromosome today. And so I think it's very interesting that the same mutation can cause different blood disorders. What that means is we have much to learn. And so the JAK2 mutation called MPL and something called CalR, or calreticulin, are really the most common that we see. Next slide, please. This is just a slide. It's a little fuzzy. I apologize if it doesn't come out as well. But you can see here that where it says EPO-R, and then you see the JAK2 on the left side. To the top of the slide is outside of a blood cell, and that's the cell membrane that it sits in. And when it's stimulated by a variety of different proteins that float in the blood, you see the JAK2 then becomes activated. That's what those little P's mean. And then there's another protein called STAT, and that gets activated by JAK2. Now, the nucleus inside of a cell is represented by that membrane layer on the bottom of the slide there. And STAT then signals for proliferation and growth of the cell. And off to the side there, there's something called PI3K, or phosphonadiol 3 kinase. I ask you to just file that into your memory, because we're going to come back to a drug that may have a role in importance later on. When the JAK protein is mutated, it doesn't need to be stimulated anymore, thus leading to the proliferative advantage. Next slide, please. And these pie charts summarize how these acquired mutations are represented in the 3 disorders. And so P-Vera has the highest incident, and you'll see anywhere from 90 to, in this slide, it says 97% of being JAK2 positive. Whereas in ET and myelofibrosis, it's about 50%. The other mutations that I offered in the previous slide, MPL and calreticulin, those are represented a little bit less, almost non-existent in P-Vera. And so now we're starting to see we have different blood disorders that clinically can be different. And now we're starting to have the genes and the genetics to match that. And maybe that's the beginning of the understanding of how each of these are different. Next slide. There have been a host of other genes, and there's something called next generation sequencing. With the advancements of DNA technology and other genetic testing over the last 2 decades, we now can test for a variety of different mutations. Now this slide, some of those genes are a little bit small, but hopefully I can see them so you can see them also. And there are genes like TET2 and ASXL1 and something called EZH2, DNMT3A. These are more common and can be very prognostic in some of our disorders, especially in some of the chronic leukemias and so forth. For myelofibrosis, for example, in patients that have ASXL and TET2 mutations, your clinical course can be much more aggressive than what the scoring systems forecast. As someone who does bone marrow transplants, what we now call cellular therapy, that's important because especially for our younger patients who may have a related donor or a perfectly matched donor, we may consider transplant sooner in those individuals than waiting for the natural course of the myelofibrosis to potentially turn into acute leukemia. These other mutations that we see, for those on the call that are familiar with AML or acute myelogenous leukemia, these are some of the same mutations that are important in the management. And there are targeted agents and oral chemotherapies for IDH1 and IDH2 as an example that are changing that disease. Next slide. The expected lifespan and survival rates, it almost mirrors the progression to AML. So as the risk of progression to AML increases, our survival can decrease, unfortunately. And you see myelofibrosis, average survival is about 6 years, and P-Vera about 14, and ET about 20 years. So obviously there's a need for better treatments for myelofibrosis and P-Vera also when it decides to turn into myelofibrosis or head towards a leukemic state. Next slide. So this is an incredibly busy slide. I included it and I offer it for a few reasons. One, this is to remind me how much more complicated the management of our patients has become. The NCCN, the National Comprehensive Cancer Network, it's a battery of member institutions and committees that make suggestions for how to manage our patients with blood cancers and blood disorders. And so having sat on some of these committees in my academic days, very, very good institutions, incredibly smart people, and usually there's a consensus opinion. And so for those of us now in the community and the private practice setting, these pathways are very, very important, and they've become very complicated. And that's the point here, is that we don't just have a treatment or two or therapy that we try for everyone, so to speak, when say phlebotomy fails or other interventions like aspirin. There's much more of a thought process. These pathways are a byproduct also of the increasing knowledge of the genetics and the mutations that I reviewed in the immediately preceding slides. So for P-Vera, this really the standard, what we get from this slide is really phlebotomy and maybe a drug called Hydrea to control the red cell count. Next slide. As the P-Vera may progress, maybe the white count starts to get high, the platelets are affected. The next mainstay of treatments beyond phlebotomy and aspirin are a drug called hydroxyurea, an older drug called interferon or pegylated interferon. And then beyond that, we have a drug called ruxolitinib. Next slide, please. And so for essential thrombocythemia, again, lower risk, maybe just a high platelet count, especially in our patients that may be in their third or fourth decade of life. We may not choose to lower those platelet counts if, say, they're 400, 500, 600, but an aspirin is usually required, and workup for bleeding disorders, something called von Willebrand disease, and so forth. Next slide, please. As ET, including the platelet counts, become higher and higher, we may add hydroxyurea. There's another drug called anagrelide that specifically lowers platelet counts, but that has been tested in clinical trials against hydroxyurea. And there was a trend, although not definitively, to maybe some additional cardiac and CNS and stroke events. So for the most part, at least in my opinion, hydroxyurea remains a mainstay over anagrelide. Sometimes we add anagrelide in our pathways here in our practice. Beyond that, once ET may look like myelofibrosis, the JAK inhibitor ruxolitinib can be used. Next slide. And finally, getting to myelofibrosis, lower risk, so to speak. We used to use hydroxyurea in the past, but now ruxolitinib, the JAK2 inhibitor, has proven to be a little bit better than hydroxyurea. We still use hydroxyurea, especially if the white counts are high. But ruxolitinib, as you can tell from P-Vera that changes to myelofibrosis, or ET that changes, ruxolitinib becomes important in those particular individuals. And now we start to reach for it. It certainly helps symptoms much better than some of the other interventions that we have. Pegylated interferon can work and can be useful. If anyone is attending tonight that has been on that, we would certainly like to hear if you had difficulty with that, because the courses are long and the symptoms related to that treatment sometimes can be as bad, if not worse. So for me, I've used pegylated interferon. I've tried to avoid it because I've seen a lot of patients have more problems with the treatment than what they're dealing with. Next slide, please. And then for higher risk myelofibrosis, we start to think about a cellular therapy like a bone marrow transplant from either a related or an unrelated donor. We still can use ruxolitinib, and now there's a new JAK2 inhibitor called fedratinib that can be very helpful. I will say that in folks that may have been on ruxolitinib, I've used fedratinib to bridge to get to a transplant. And in my non-transplant patients, I've also moved to fedratinib when ruxolitinib does not help the symptoms as far as an enlarged spleen, night sweats, fatigue, poor appetite, and so forth. So there are some advances that we didn't have in the years past. Next slide, please. And so anemia, as far as related to these, can be very problematic because many of our medications like hydroxyurea and ruxolitinib can be harder on the counts than they can be helpful. And so there are some older medications like danazol, for example, and medicines that we use to treat multiple myeloma and lymphomas like lenalidomide and thalidomide that are not used very often but can still be useful. Next slide, please. And so as we talked about the need to improve survival, especially when these disorders progress, I went over 3 blood disorders and talked about 5 or 6 drugs. There's not a lot of other blood cancers that I could do that quickly. We have 10, 12 more medications. And so there definitely is a need for these disorders for improvements, and not only improvements in response, but improving quality of life and especially outcomes in survival. Next slide, please. And so this is just a simple chart to go through some of medications over the last maybe 5 or 7 or so years. Danazol, as I said, is part of the NCCN pathways. It's been proven to help with enlarged spleen, generalized symptoms. Pomalidomide is yet another version of lenalidomide and thalidomide. Thalidomide can cause constipation and peripheral neuropathy. Lenalidomide can drop the blood counts. So pomalidomide has also been shown to be helpful. There's a medicine there called 5-AZA or 5-azacitidine that we use for myelofibrosis. For MDS or myelodysplastic syndrome. It can be useful for myelofibrosis patients, especially as their white count gets higher and maybe starting to look more like acute leukemia than a myeloproliferative neoplasm. There's a drug called panobinostat that has been lukewarm as far as helping the spleen, but it can help symptoms. It hasn't quite made it through full clinical trials for FDA approval. There's a drug called it still has a lab designation, BKM-120. And if I can have you recall from my slide of the JAK2 protein, I pointed out that thing called PI3 kinase. And that's what this is directed towards, stopping the signal from the cell membrane to the nuclear membrane. And again, some promising early response, but still needs more investigation. And the last one there, the LDE225, there's a protein called hedgehog that is important in intracellular signaling also between the cell membrane and the nucleus. And that has shown similar benefits as far as symptoms, but much more testing and more clinical trials are necessary. Next slide, please. So this is a chart here. I made this before fedratinib came to light, so to speak. So fedratinib is not included here. But at least for myelofibrosis, where I think there's more, if not most, of the need of help and assistance. So you can see here, ruxolitinib is paramount. We have hydroxyurea, which is HU is the designation, maybe interferon. And then in the next lines, we have some newer drugs that are showing really promise. The momelotinib is a pan-JAK inhibitor. It is in the middle of a phase 3 trial called Momentum is the acronym. And it's specifically meant to address the anemia and myelofibrosis. It is being compared against danazol, and it has been shown to be non-inferior to ruxolitinib. So we're certainly out on the lookout for that particular drug as it comes to light. The next, pacritinib, also is an interesting drug, and it's meant to help with the fibrosis or the scarring in myelofibrosis. And so primary myelofibrosis, post-fibrosis, PVERA or ET, these are meant for those particular patients. There's a very large trial called Pacifica. It's a phase 3. A few years ago in 2014 and 2015, we had this drug in the early phase clinical trials. It was at a higher dose that's being tested now, and they reduced the dose. It has better GI side effects and toxicities, or I should say less. And so it'll be very exciting to follow this drug to see if it could actually help with the fibrosis that occurs, because we don't have that at the moment. The drug PRM-151 is a drug that are for folks intolerant of ruxolitinib. It also has been shown very good promise to decrease the scarring and the fibrosis. And it mimics a drug called, I had to write this one down, pentraxin 2. For some reason, I couldn't remember that. That's a protein that blood cells make that is less. And so this drug offers a replacement for that to help with the fibrosis. And then the imetelstat is a drug that inhibits proteins that make our chromosomes smaller as we get older in age. And that's been shown to be important here. So out of all of the potential targets, I find these more exciting, and possibly in the next few years, maybe drugs that might be more readily available and be able to help our patients. Next slide, please. So a couple fun advancements in where research is currently in the field. I think hopefully many on the call are familiar with CRISPR. And so we're looking at CRISPR to identify new targets, help manage mounds of data, and try to find connections. And so there is editing of the JAK2 mutation in vitro samples that are being banked. And so there may be clinical information that will come forward that will help us with either how to use existing drugs better, maybe in different combinations, or identify new targets like beyond TET2 and IDH2 and so forth. Next slide, please. And this was a really fun one that I found. It's a yoga study. And as I mentioned before, symptom management is very important in many of our patients. And so I found this very interesting, that there was a course of yoga, completed 60-minute online sessions. Very important in the world of COVID today to do things remotely, right? And so you can see 68% of folks were satisfied or very satisfied, and improved this thing that we call the MPN-10, which is a scoring system for symptom management. So here, to me, it's beyond just the science and just the art of taking care of patients. It's really the holistic approach of approaching our patients' care. So I'm not going to find many yoga studies for acute leukemia and multiple myeloma just yet. So I found this very, very interesting. Next slide, please. And so for here, the WHO diagnosis and the science certainly does not tell the whole story. And so I have a few other slides here. I'll stop here, though, because really I believe it's truly important for patients to be their own advocates, to seek out healthcare professionals, healthcare teams. It's not just the low blood counts that lead to certain symptoms. It's not the spleen being enlarged. These symptoms can be variable from day to day, week to week, month to month. These disorders can change, as hopefully I showed in the past slides with the circles overlapping. And so it's really a collaborative effort across the board. There is a lot of information out and available on the internet. A lot of it is not policed and edited. I think as a provider, that can be a source of frustration with many of our other blood cancers. But for here, with the less common nature and how information is available through the cancer support community, there's an MPN site. There are the academic sites that do an incredible job of getting information out. The Leukemia and Lymphoma Society. And so, again, I really believe that it's a collaborative effort, and to be able to especially manage symptoms as well as we can, particularly in those individuals that we can't truly affect the biology and fix the marrow, so to speak. And so with that, I would like to end, and I appreciate everyone's attention. We have some time for some questions.
So now I'd like to welcome Dr. Barbara Walker, who will lead us in an experiential mind-body workshop focused on stress reduction interventions. Dr. Walker currently serves as an integrative health and performance psychologist with the Department of Psychiatry and Behavioral Neuroscience at the University of Cincinnati College of Medicine and UC Health, where she provides consultations to a wide variety of patients to facilitate their optimal effectiveness, whether for coping with an illness or injury or a desire to improve their performance on the job, at home, or within their daily lives. She specializes in the use of biofeedback and mindfulness techniques as tools for teaching self-regulation. Barbara also continues to teach both sport and positive psychology as an associate adjunct professor at the University of Cincinnati. Dr. Walker earned her master's degree in health psychology and her doctorate in clinical psychology with an emphasis in exercise and sports psychology, and is a licensed clinical psychologist. Barbara is a regular presenter at local and national professional conferences and workshops, has authored multiple chapters in professional texts, and is a regular contributor to national periodicals. She has appeared as a guest expert on multiple radio and television programs. She currently serves on the board of directors for the Cincinnati Flying Pig Marathon. She is a member of both the American Psychological Association and Association of Applied Sports Psychology, as well as a member of the Sports Psychology Registry with the United States Olympic Committee. Barbara demonstrates a lifelong passion for peak performance, principles applying them in her own professional and personal life as a former competitive athlete in sports of marathon, triathlon, duathlon, and cycling. Please help me in welcoming Dr. Barbara Walker.
So again, with mindfulness practices, you're really practicing kindness towards yourself. You're creating a new normal for yourself, kind of creating a sense of purpose, creating some space for optimism and gratitude. And it's really practicing this with some regularity allows you this proper mindset to kind of build some strength, resiliency, and hope, which is what I find really helpful with a mindfulness practice, especially with some of the things that you guys all have going on. So here's some resources here, but we can kind of stop these, or you can take a pic of those if you want. But I wanted to, and I can talk more about these in a moment, but I wanted to be able to do a little bit of an experiential, if you will. So hopefully people are wide enough awake. It's only 7:40, although it's getting dark now, so it seems like winter's coming and we need to go to bed soon, right? But let's go ahead and just do a little mindfulness exercise. Again, this might be really familiar to some of you, and some of you just never done this. So I'd love to kind of hear your feedback at the end on how you feel. But so go ahead and just get yourself in a comfortable position, and perhaps you're already in a comfy position, but think about you kind of sitting up, kind of upright, almost like in a dignified position, as we call it in meditation. So not laying back too much, unless you really want to completely lay down flat, that's okay too. Maybe not slouched, because we want to be able to give some area of in our stomach and our lungs to be able to breathe. So, you know, when you're sitting up, head up, shoulders back a little bit, not tense, but just comfortable. And then just put your hands wherever you feel comfortable. So on your lap, or if you're lying down flat on your back, you know, put your hands out with no appendages touching. So if you feel comfortable enough with that, either avert your eyes or just go ahead and close your eyes for a moment. And I'm just going to talk you through this meditation, which is really a gratitude meditation, for breath, body, and mind. And so go ahead and take a full breath in through the nose if you can. And find yourself sitting up a little taller. And as you exhale through the nose, if you can, just release the shoulders. And take a few moments with your attention to your breath, settling into a neutral, upright posture. And allow your belly to soften, shifting your shoulders back ever so slightly. And lower the chin so that the back of the neck is neutral and long. And with complete awareness of your breath and posture, begin to intentionally generate a deep sensation of gratitude for the breath itself. And as you watch, notice the breath moving in and out through the nose. Remember how precious this one breath is. And this next one too. And invite in the spaciousness of awe and wonder as you sit with the next 3 cycles of breath. And then draw your attention to your heart. Feel the heartbeat beat. Perhaps in the quietness you can hear. Still aware of your breath, but noticing, listening to the heart. Inviting in awareness of the miracle of the heartbeat. As we sit with this noticing for 3 cycles of breath. And still aware of the breath and the heartbeat, draw awareness to the form of your human body. Here, functioning, breath breathing, heart beating. Noticing whatever it is that arises when we notice the unique fortune of our human birth. Here in this human body, you have everything you need to do to awaken. You have everything you need to find happiness, contentment, and joy within. There is infinite capacity within you. Infinite capacity for awareness and gratitude. Breath breathing, heart beating, a mind that can notice, understand, feel, and discern. A mind whose capacity for awareness, understanding, and growth is infinite. A mind whose capacity for noticing its true nature is right here, right now, in your hands. Smile on the breath. Smile on the heartbeat. Invite in love for this body and kindness towards this mind. Rest here remembering you have everything you need. Resting in gratitude for it all. And in this mind, with its infinite capacity, as it tries to draw you away, keep coming back to the wonder of this one breath in and one breath out. Magic of the heartbeat, the beauty in being here. Just a couple of more deep breaths. And whenever you're ready, you can open your eyes. Everyone awake? We're not next to each other, so we can't elbow each other or poke each other to wake up. So that's a gratitude meditation. There's so many different things, but that's a guided one, obviously. I'm guiding you through. But there are a lot of different apps out there now. Calm app, I believe that's still, I need this one particular slide. I think it's still free right now during COVID. There's Insight Timer, which I love. The reason I like Insight Timer, if you decide to download Insight Timer, it has, it looks like there's going to be a premium, but you can swipe up and it goes away, unless you take some of their courses. But it has, I don't want you to get overwhelmed, but it has like 45,000 meditations on it. But what I love about it is it's from people all over the world, and it's categorized. But I love so many different people's voices and ideas. And so, so if you don't like one person's voice, you can go to somebody else. We were doing mindfulness meditations in the integrative medicine and psychiatry department. I was actually doing them like a lot during COVID, Monday through Friday, and then we did them a couple times a day at some one point. We're back down to Mindful Mondays at 8:30. So if you're ever interested in that, the more the merrier. So if you all want to join that, it's just a half hour. It's a guided meditation, kind of in and out. So I can send you the link to that if you reach out to me. We're also doing some mindfulness meditation for optimal health, which starts in October. And that's specifically for people who have dealt with cancer or are dealing with cancer. So that's something that you can join. It's a 4-week little class about learning about mindfulness meditation. And then we're doing televisits. We're doing in-person visits at this point too. And obviously, you know, support groups, Facebook groups, however you want to reach out to other people, for sure. I think that's just make sure you stay connected. So I will, I have a few minutes if we want to open this up for any questions or any comments or thoughts or whatever. I'm here.